Patrick, thank you very much. I'd like to say what a pleasure it is for me to be here this evening. I'd like to congratulate Patrick and Richard and the families of patients with Dagos disease for putting together this wonderful symposium. I was there in the Ether Dome this afternoon, and I couldn't help but think how many cases of untreatable diseases have been presented in that amphitheater in the last 150 years, and how many of those diseases are now treatable and curable. And it all began with discussion like that. So thank you very much for the invitation to speak tonight. I am going to talk about Buerger's disease, which is similarly frustrating as treating Dagos disease. Probably not as frustrating, but as a clinician, I have certainly seen more of Buerger's disease. I learned more about Dagos disease today than I ever knew. But I've seen quite a bit of Buerger's disease, and it can be a frustrating entity to treat. There are a number of important differences that are striking between these two disorders, and I think it will put into relief Dagos disease, particularly in light of Patrick's overview. So I've subtitled this Trying to Track and Treat a Very Different Beast, because Buerger's disease really is a different beast from other forms of vasculitis, just as Dagos disease is. This is the classic picture of Buerger's disease involving the distal extremities leading to gangrene and necrosis of the fingers. And immediately, on seeing this picture, you'll notice differences between Buerger's disease and Dagos disease. Dagos does not cause digital necrosis like this. It involves a different size blood vessel, which is one of the points that Patrick just made. So one can't talk about too much in 20 minutes, but what I hope to do is to illustrate how Buerger's disease is different from other forms of vasculitis and from Dagos disease. I'm going to tell you about two illustrative patients that whom I've taken care of, and along the way show you some points and pitfalls related to these two cases. So first of all, how is Buerger's disease different? Well, you saw in the first picture that I showed that there is an important difference in the size of blood vessel involved. We emphasized again and again today in the Ether Dome about how Dagos disease involves the small blood vessels in the skin, in the brain, in the GI tract. Buerger's disease involves medium-sized blood vessels, and it has an entirely different distribution. It doesn't really involve the skin. It involves the skin only in that it causes secondary necrosis because of the involvement of deeper blood vessels. It almost never involves the GI tract. It almost never involves the brain. There are case reports only of involvement of those organs. Second, the histopathology of Buerger's disease is very different from other forms of vasculitis. Rather than having inflammation within the blood vessel wall, which is the definition of vasculitis, Buerger's disease has some inflammation in the blood vessel wall, but the really characteristic disease feature is a highly cellular thrombus, a clot, which occurs within the blood vessel wall and completely occludes it. And this thrombus consists of a number of different cell types: lymphocytes, polymorphonuclear cells, giant cells, and microabscesses. The microabscesses and giant cells take a while to occur. It's a very subacute process, not occurring only over days. And another important difference from other forms of vasculitis is there is no fibrinoid necrosis, which is a distinctive pathological finding. For risk factors for Buerger's disease is really unique among different forms of vasculitis because it has a very strong risk factor. You don't get Buerger's disease if you don't smoke cigarettes, and it is a striking association. Obviously, not everyone who smokes cigarettes gets Buerger's disease, but you can't get Buerger's if you don't smoke cigarettes. There's no other form of vasculitis with such a strong risk factor. And with regard to treatment, I'll say a word or two at the end, but treatment is similarly frustrating. And I'll illustrate that in talking about the two patients. Now, in doing a little bit of research for this talk, I found out something about Leo Buerger, after whom the disease is named. He was a pathologist, primarily, who lived in New York and described the disease in the early 1900s. He was also trained in urology, however, and he invented a cystoscope, an instrument for looking in the bladder, which was used for decades in the United States, up until only a few decades ago. Interesting point I didn't know about Dr. Buerger. This is a picture from Buerger's original monograph of the disease, and this is from an amputation specimen, an amputated lower leg, and you can see this is, the knee was up here, the foot was down here. This is the blood vessel wall with a little bit of inflammation here, and then this highly inflammatory thrombus. It's no wonder that people lose fingers, toes, feet, and hands when they have this disease, because there's not a lot of blood getting to the distal circulation. So Buerger described 11 patients, perhaps it was fewer, but it was 11 amputated legs of young men who were smokers. They were all males. They ranged in age from 25 to 40. And because they lived in New York around Mount Sinai Hospital, at the time a very Jewish neighborhood, all of these patients were Jewish. So it was thought early on that being Jewish was a risk factor for this disease. We now know that that is not true. The risk factor is smoking. There were some other earlier misconceptions about the disease. The disease had actually been reported in the medical literature, although not well described, and it had been called pre-senile spontaneous gangrene and endarteritis obliterans, both terms that don't really get to the basic central pathology of the disease. Buerger recognized in his 1908 monograph, and it's striking that in almost 100 years now, we truly have learned very little more about this disease. But Buerger identified the nature of the process when he wrote, "We are dealing here with a thrombotic process in the arteries and veins, followed by organization and canalization, attempts by the immune system, the body, to dig tunnels through those clots to get blood to the distal extremities." And he named the disorder thromboangiitis obliterans. So the most commonly involved vessels are those in the hands and feet. So Buerger's disease occurs here, in the wrists, and the analogous vessels in the lower extremities. Now let me move to tell you about the first of two patients. This is an 18-year-old woman I evaluated probably 8 years ago now. And she had driven about 3 hours to come to our vasculitis center, and she showed up with toes like this. She'd been healthy all of her life, but had painful toes. Now, initially, she had her first symptom of the disease, in retrospect, had been some red spots on her legs that were tender. She had seen her primary care physician. Her primary care physician had not known what to make of it. So when she developed this problem with her toes, she was sent down to Johns Hopkins. We'll come back to those painful red lesions in a second. Buerger wrote that the disease presents with indefinite pains in the foot, in the calf, or in the toes, particularly a sense of numbness or coldness whenever the weather is unfavorable. So what he's describing here are nonspecific pains in the feet, although it can occur in the upper extremities as well, and claudication, pain in the distal extremity when the patient exercises because the distal extremities aren't getting enough blood. This is the other side of the patient's feet, and really they don't look too bad. Not as bad as her angiogram, which I'll show you in a moment. But when I first saw her, I didn't know that this was Buerger's disease, and making the correct diagnosis is often a challenge in vasculitis. In this previously healthy young woman who showed up with these toes, her blood pressure was elevated for a slender young woman, 140 over 100. So I suspected there might be another form of vasculitis going on. In particular, I was concerned about polyarteritis nodosa. So we admitted her to the hospital overnight for some additional testing and performed angiograms of not only her feet, but also of her mesenteric vessels, her GI tract, to exclude vasculitis that might have been subclinical in that area, perhaps involving her kidneys, leading to high blood pressure. Now, these angiograms were not hers, fortunately, because they show some striking abnormalities. I think you saw this slide earlier today, but this shows microaneurysms in a patient with polyarteritis nodosa, another medium vessel vasculitis. And one also sees microaneurysms in the kidney here and in the splenic circulation here. This was not our patient's angiograms, but this is what I hope to exclude in doing the angiograms. This is our patient's mesenteric angiogram, and you see nice, beautiful, smooth blood vessels with no areas of occlusion and no microaneurysms. However, her angiograms in her extremities looked fairly horrific. This is her right leg, and it's interesting. This blood vessel here, down in her feet, is actually pretty normal. But the blood vessel that is supposed to feed that one just kind of peters out here and stops. And then this blood vessel here also stops, fills with a collateral circulation, comes down to above the level of the ankle where it stops, and is able to continue to perfuse the foot only by establishing a collateral circulation here. This is very characteristic of Buerger's disease, to have areas of perfectly normal artery interspersed with 5 or 10 centimeters of flagrantly abnormal, obliterated artery. And this is her left leg. You can see this artery here comes down and just stops, bang. And right below there is a thrombus. It's a wonder that she managed to have a foot at all, given blood vessels that look like this. They're just spider webs. So a point about this patient's presentation is those red dots that she had are actually often the first clinical presentation of Buerger's disease. The diagnosis could have been made then, although it is very seldom made then, but it could have been made before the onset of such severe digital ischemia. And Buerger actually recognized this. He wrote in 1908, "Most interesting is the acute stage or earliest lesion, which occurs simultaneously with thrombosis, acute thrombophlebitis." So an astute physician seeing a patient who is a smoker who presents with red, painful lesions on the lower extremities could make the diagnosis by biopsying at that point, and then achieving a very effective intervention by encouraging smoking cessation. These are what these lesions look like. So a point that I always give when talking about Buerger's disease, there are other illnesses that can look like Buerger's disease in the extremities, but one has to think of Buerger's disease and make that diagnosis when the ischemia is so severe in the extremities, but there is no ischemia anywhere else. Not in the brain, not in the skin, not in the GI tract, kidneys, lungs, etc. There are a few other symptoms of Buerger's disease. They're usually not picked up, though, because by the time it's diagnosed, the overwhelming problem is the ischemia in the extremities. Buerger's disease, like other forms of vasculitis, can present with an inflammatory arthritis that in the literature suggests that some of these patients have an inflammatory arthritis, polyarthritis, looking something like rheumatoid arthritis, sometimes for several years intermittently before their presentation. This is intriguing. And peripheral nerves can also be involved, but not because of vasculitis of the vasa nervorum, as other forms of vasculitis cause, but because of a fibrosis that occurs around the peripheral nerves. It's sort of a spillover inflammation from inflammation in the arteries and veins. So patients can have numbness in their extremities. Otherwise, as I've mentioned, other organ system involvement is very rare. This is also from Buerger's original disease monograph. It illustrates that Buerger's disease not only involves the arteries, which you see here, a thick-walled vessel. It also involves the veins, a thinner-walled vessel. And then this is a peripheral nerve. Nerve, artery, and vein tend to run together in a bundle. And the peripheral nerve is also involved here by a fibrotic process. So how did patient 1 do? Well, it was a very good story. She did beautifully. We made the diagnosis on her second hospital day after getting the angiogram results, and she stopped smoking. And a month later, she was feeling much, much better. You can see that her left toe that had been involved here is actually significantly improved. She is losing a bit of her nail here. She eventually sloughed that, and now I think Buerger's disease is just a bad memory for her. So she did extremely well. Obliteration is a word that Buerger used again and again in his original description. And he wrote that the beginnings of the obliteration are not to be sought in the capillaries nor in the finest branches. It's the medium-sized vessels. If we follow the vessels upward, we see a sudden cessation of the process, so a normal appearing blood vessel. And in a number of instances, we find that some 5 or 10 centimeters of a vessel's length is closed, and that portions above and below are apparently normal. And this illustrates that point again. And this is another angiogram from a patient with Buerger's disease. This is I need to show you here, don't I? Vessel in the arm, in the upper arm near the shoulder, actually very normal looking. But when we get down into the forearm, the blood vessel here just stops suddenly. Okay, I want to move on to patient 2 now. Who was also referred, and the referring physician had indicated that he had a patient with scleroderma who urgently needed to come to our hospital. These were the patient's fingers at presentation. There were a couple of problems with the diagnosis of scleroderma. First, the patient had splinter hemorrhages, which you can see here. Splinter hemorrhages don't occur in scleroderma. Second, the hallmark of scleroderma is sclerodactyly, one of the hallmarks, and this patient actually has perfectly normal-looking skin on his distal fingers. So I really didn't think the patient had scleroderma, but I didn't know what he had. There were a number of red herrings in this case, and in preparing this, I looked up where red herring comes from. I don't know if you know anything about fox hunting. I don't know very much. But apparently in fox hunting, the hunters have the fox before the hunt starts. And before they release the fox so the dogs can go chase it, they would wipe a smoked herring over the fox's tail to throw the dogs off the scent, and then they release the fox and off they go. So we were trying to diagnose Buerger's disease, and there were a number of red herrings. First of all, there had been the earlier diagnosis of connective tissue disease, which I thought wrong. The patient was also hepatitis C positive, which can cause vasculitis. And the patient, we didn't know it at the time, was HIV positive. So there were quite a number of confounders in this case. These were his fingers on presentation. You can see a modeling there, and they were quite cool to the touch. And these are his feet, and you can see purple discoloration here. One point is that he had no purpura. Purpura is probably something that you saw in the afternoon in the discussion of other vasculitides. Purpura is a manifestation of small vessel vasculitis. And small vessel vasculitis, such as this case associated with hepatitis C, often has confluent purpura. He didn't have any of that. This was his angiogram of his arm, perfectly normal looking. Around his elbow here and his distal blood vessels, this looks pretty good. But when you get down to the level of the wrist, you see what are called corkscrew collaterals. The blood vessels desperately trying to move blood forward and growing in new ways, trying to get around the clot that has formed. This is the angiogram of his feet. And it looks very much like that of patient 1. You can't even tell where the blood vessels to the feet are because they're completely obliterated. This is his right foot, so going toward his great toe, but there's very little circulation to the other side of his foot. So Buerger wrote about critical limb ischemia in this disease, the development of a blister, hemorrhagic bleb or ulcer near the tip of one of the toes, and when this condition ensues, the local pain becomes intense. So it was very difficult taking care of this patient because I essentially had to watch as he proceeded to requiring amputation of one lower leg. And I didn't make the diagnosis with all of these red herrings until I realized that one day after going by to see him for about a dozen days, he was never in his room. He was always out smoking a cigarette. And that's when it dawned on me that that was what the diagnosis was. So these are the blebs that Buerger wrote about. These are in his fingers early on. And this is in his feet. You can see these blebs appearing. This is a few days later. And a few days later, and at this point it was pretty clear that the patient was going to require an amputation. And this is from his amputated leg, and you can see just clot within the blood vessel wall with an attempt at recanalization here. So this case calls to mind a couple of pitfalls. The first is on the part of the physician believing that Buerger's disease can be treated with anything except smoking cessation. And the second is on the part of the patient believing that Buerger's disease can be treated with anything except smoking cessation. Patients who stop smoking very often, in a majority of cases actually, preserve their limbs and don't require amputation. But among patients who continue to smoke, amputations occur in an extremely high percentage. And there is just not anything else to do for them right now. I tried steroids in this patient. I tried cyclophosphamide in this patient before I knew he was HIV positive. And anticoagulation, no effect at all. So this is after a couple of amputations of fingers. And you can see here new splinter hemorrhages in his nails. So he was still smoking. And the unfortunate man proceeded to undergo bilateral below-the-knee amputations and lost every finger on both hands. before his disease. There was nothing left for his disease to attack. So one final pitfall, corkscrew collaterals that I showed you, and you see right here, are not specific for Buerger's disease. Other forms of vasculitis can also do it. And this is a patient who looked for all the world like he might have Buerger's disease with ischemia of his toe. But his angiogram showed an aneurysm just behind his knee. And Buerger's disease doesn't cause aneurysms. Polyarteritis nodosa, as I've shown you, does. So this patient had polyarteritis nodosa. And then this is actually my final slide, and it points up a pitfall in the ACR slide collection. This slide is depicted or called Buerger's disease, but it's not Buerger's disease. I've just told you that Buerger's doesn't cause these microaneurysms. So here in the ACR slide collection, we have a fallacy about the disease. I think this patient had polyarteritis nodosa. So with regard to treatment, at this point I was going to throw it open and see if anybody had any suggestions, because other than smoking cessation for Buerger's disease, which is sometimes notoriously unsuccessful, we really have nothing else at this point.